Hi everyone, welcome back. Welcome to Medical Science. Thank you for tuning in to our second video here. Today we're going to talk about the cardiac cycle. Everyone, thanks again for tuning in to our second video on the cardiac cycle. Last time, for those of you that watched it, we talked about pressure volume loops. And in the pressure volume loops, I went and drew the loop and I discussed with you guys the different phases of a cardiac cycle, which usually typically goes from lasts about 0.8 of a second in duration. So what I did last time was I sort of drew that out and I showed you different points in the pressure volume loop where certain things were happening, such as the aortic valve opening, the mitral valve closing, stuff like that, systole, diastole, the volumetric phases. I showed you guys all of that. Now I'm going to take things on from a cardiac cycle standpoint. So this is what we call a Wiggers diagram. And this is very standard sort of thing in physiology that you see in textbooks, lectures, stuff like that, where faculty will superimpose these diagrams and they will show everything to you that kind of is happening on a beat by beat basis in the heart as well as in the aorta. So right here, we have a breakdown of the aortic pressure, the atrial pressure, the ventricular volume, and then we have our electrocardiogram as well as the phonocardiogram. So pretty much everything is labeled here. What I want to try to do is kind of walk through the cycle and see if we can put things together as we go through it. Oftentimes we'll remember each thing on an individual basis, each of these diagrams, but maybe if we can try to put things together today, this sort of brings the whole picture together and maybe understand it better, and maybe it just reinforces some previous concepts. Okay, so let's begin. So we'll start down here, all right, where the mitral valve is closed. And what we're trying to show here is that when a contraction, when a beat ends, what happens is your ventricle is relaxing, and as your ventricle is relaxing at this point, your atria, which usually deposits blood to the ventricle, at this point, the valve that controls that flow of blood is closed, and that is because our ventricular pressure at that point is still greater than the atrial pressure. So when that valve is closed, when the ventricular pressure is starting to build up and it's greater than the atrial pressure, that pressure builds up, right? So we're now looking at systole. As we can see down here, we're looking at systole. So we're looking at when the beat begins, when the heartbeat begins, when the heart starts contracting, the ventricle is contracting, the sarcomeres and the cardiomyocytes are beginning to contract, and they're creating tension, a force on the blood, a back pressure on the blood to push it a certain direction. And everything is coordinated, so we know that it's going to go out into the aorta. So now we're starting to develop that pressure. And as we develop that pressure, initially there is no change in the volume. And the reason for that is because we also have our aortic valve, which is closed at this time. So we're not up here yet. We're still down here where the aortic valve is still closed. So since the aortic valve is closed, the mitral valve is closed, the blood really has nowhere to go right now. It's just sitting in the ventricle. Everything is contracting, building up pressure. Once we reach a certain pressure, which is the resting diastolic pressure in the aorta, which is set here, textbook at 80. Once we reach that pressure, the aortic valve is going to open. It's going to open, and the opening of that valve will cause the ejection of the blood to occur. While we're here, I want to coordinate certain things. Like we said, we would try to coordinate this diagram. So what's happening is we reach here a peak of the ejection, and then we start to taper off. So we reach this peak right here, and then we start to taper off. Well, why is that happening? So the reason that's happening is you can see down here, this is called the T wave. So there's the T wave is labeled here. So this is our T wave right here. So if you understand electrophysiology, you know that there's the P, the QRS complex, and the T wave, very basically speaking, and those are indicative of whether the myocardium is in a depolarized or a repolarized state. So as many of us know, in physiology, repolarized is referring to a relaxation state. So here what's happening is everything is sort of driven based on the electrical impulses, which begin at the sinoatrial node, travel through our AV bundle and down via the bundle of His through the Purkinje fibers, and that carries, that electrical stimulus is driving the contraction of our cardiomyocytes. So now the impulses going away, and what's happening is we have a relaxation until the next beat begins again. So what's happening in this relaxation is we repolarize. As we repolarize and certain cardiomyocytes are beginning their relaxation, we start to see a decrease in the pressure. Ultimately, what happens is the pressure is going to go below the pressure that's present in the aorta, and also the backflow of blood from the aorta will start to occur. So what happens is as the pressure in the ventricle decreases, the blood now is going to start, again, we have to remember, blood flows from high to low pressure, from high to low pressure, right? Everything is flowing from high to low. Things are following gradients. That's the premise, basic premise of physiology. Things are going from high to low. What we're going to see is when those cardiomyocyte, when that pressure in the ventricle starts to decrease, the blood is going to try to reverse its flow and start to move back into the ventricle. But what happens is as that blood starts flowing back, the semilunar aortic valves, they close shut. And as they close shut, the blood itself remains in the aorta, and nothing flows back into the ventricle, and the ventricle pressure, as the repolarization down here continues, that ventricular pressure starts to drop. Now, again, it's important to remember at this point, our aortic valve closed because the pressure in the aorta was greater than the pressure in the ventricle, and our mitral valve, as we started here, is still closed as well. So this is the isovolumetric relaxation phase. All the cardiomyocytes in our myocardium are starting to relax. No blood is moving at all in either direction, and we hit this rapid isovolumetric relaxation phase. Now, a common thing that comes up is this phase, this part right here. We see when we look at the red tracing of the aortic pressure, we see it sort of coincides exactly with the way our ventricular pressure curve is going, right? Blood comes in. As blood comes in, the aorta receives that blood, pressure goes up, pressure comes down. Now it's important to remember that the aorta is a very elastic, it's an elastic blood vessel. It's an elastic blood vessel. So what happens is as it receives that blood, it starts to stretch. It starts to stretch. So there's a literal expansion of that aorta. And then once the semilunar valves close and there's no pressure coming in from the ventricle, what they do is this creates a transient uprise in the aortic pressure, which is known as this dicrotic notch. So this right here is our dicrotic notch. Okay, so that dicrotic notch is due to the transient increase in pressure that we see is due to what's called the Wind-Kessel effect. And that basically happens, the aorta is distended during systole, and then during diastole, because now we've begun our relaxation during diastole, there's a recoil, and to keep the blood moving forward in a forward direction, as the valves close, this Wind-Kessel effect keeps the blood moving in a forward direction. So that pressure that it applies keeps everything moving in a forward direction, and blood moves forward. So that's what this dicrotic notch is. And the other way to describe it is the Wind-Kessel effect, the Wind-Kessel effect. Now we have our longer phase of the cardiac cycle. So we have to remember that it's 2/3 of our cardiac cycle lasts in diastole. 1/3 of it is in systole, which sort of defines our definition of mean arterial pressure. So when we calculate our mean arterial pressure, our MAP, that is, the equation for that is usually 2/3 of the dBp plus 1/3 SBP. And so that sort of clarifies that right there, is that our mean arterial pressure is 2/3 of it is based on the diastolic blood pressure, and 1/3 of it is based on the systolic blood pressure. And because 2/3 of it is based on that diastolic blood pressure, we can see clearly in our cardiac cycle that 2/3 of it is spent in diastole. Okay, so now that we've got that, let's take a look at our ventricular volume curve. Okay, let's take a look at our ventricular volume curve. And we'll kind of take a look at the phonocardiogram at the end down here. I'll go later. So now, right now, let's focus on our ventricular volume. Okay, so we said we started off with systole, right? So we started off with systole. This is where our mitral valve was closed once the pressure in the ventricle was built up. Now, at the start of it, we talked about our isovolumetric contraction. So I went over this in our PV loop video, but basically isovolumetric, isovolumic means there's no change in volume, and that's exactly what we see right here. We don't see a change in the volume. So our cardiomyocytes, because that action potential is traveling after the in the sinoatrial node, past our AV bundle and through our His-Purkinje system, the cardiomyocytes are starting to contract because they receive the electrical stimulus. But since the aortic valve is still closed, has not opened yet, there's no change in volume. Now, as soon as that valve opens, as we see right here at the end of the isovolumic contraction, as that valve opens, we get a rapid loss of blood. So we get a rapid ejection and a decrease in blood volume, as you can see over here. And now, we were talking earlier about our T wave, right? So we talked about the T wave and how we see that decrease in pressure, and we see that because we start to see the repolarization begin right here, and it coincides with the peak of that pressure curve, and then we start to see this decrease in the pressure, and that's because now the cardiomyocytes are beginning to relax. So as they begin to relax, we see a decrease in pressure. Similarly, initially, right sort of at the peak, right before the peak, we see a very rapid, as you can tell by the slope, we see a very rapid ejection of blood out of the ventricle and into the aorta. So we see a very rapid decline in the volume. Now, similarly, as those cardiomyocytes begin to relax, as the pressure begins to decrease, we have a slowing down of the ejection of blood. So a slower decrease in the ejection of the blood, because not all cardiomyocytes are beginning to relax at once. And this becomes very clear when you go over the electrophysiology, which we can cover in a different lecture. But this becomes very clear when you look at the electrophysiology and the way the action potential travels, that things are contracting in a syncytium. That's a term that's very commonly used to describe the contraction of the cardiomyocytes in the heart, is it contracts as a syncytium. So similarly, the relaxation is also occurring in a syncytial manner, and things are not just all, the heart doesn't just all stop beating. So that allows our ventricle to relax, and there's a slower ejection of blood. And then we end at this isovolumic relaxation, and this happens right here as our aortic valve closes. There's no blood movement occurring, so no change in volume. And this part is where we reach our left ventricular and systolic volume. Right here is where we hit our left ventricular and systolic volume. Okay? So left ventricular and systolic volume, which we did show last time on the PV loop as well. So now, once the ventricular pressure drops below the atrial, so this yellow curve, as we can see here, the yellow curve right here that we see is indicative of our atrial pressure. So we talked here a little bit earlier about the mitral valve closing. Well, now that ventricular pressure, as the ventricle repolarizes, our ventricular pressure drops below our atrial pressure, and as it drops, the mitral valve will open. Our mitral valve will open. And you'll kind of notice right now these A, C, and V. These usually are referring more to the right side of the heart, and they're called jugular venous pulses. And these peaks and descents are indicative of changes in the jugular venous pulse, and I can sort of describe that as we move along in the video. But let's continue our train of thought right now, where we're talking about the opening of the mitral valve. So as the mitral valve opens, the blood from the atria, which has come in from our pulmonary circulation, if we're referring to the left side of the heart, or our from the systemic circulation, from the systemic venous system, from the rest of the body, if we're referring to the right side of the heart. So that blood will come in and pass through, as the valve opens, it'll pass through and into the ventricle. It'll pass through and into the ventricle. And you can see there's not really much of a change right now in the pressure, because this is called a passive filling. There's a rapid passive filling phase followed by a diastasis, where things sort of slow down. So there's two phases that diastole can kind of be divided into, at least in terms of the passive filling. So this initial part is the passive part, okay, of the filling. So the initial part is passive, and there's a rapid part of it, and then there's a more slower part of it, which coincides with our diastasis, a slower filling. And these, as you can see, sort of coincide with the T, the end of the T, and right before the P wave, which refers to our atrial systolic phase, our atrial systole, or our atrial contraction. So during that time, in between the next beat starting, we have this filling phase occurring. And there's, like I said, there's the passive part, and then there's the active part. So the passive has two portions to it. Now, moving on, then we have right before the filling ends, and then our new heartbeat begins, which starts with our P wave at the sinoatrial node. As soon as that kicks off, that will cause the atrial contraction to occur. And this is what we see right here in this upstroke that we see in the atrial pressure. And because the mitral valve is open right now, we also see an upstroke in the ventricular pressure. And we kind of showed this in our PV loop last time. If you look to the right side of the loop, we showed a little, towards the end of it, we showed an increase in the pressure as the volume was increasing in the ventricle, and that was to indicate that atrial systole that occurs right towards the end of the diastole. And to precede that atrial contraction, we have to have an electrical stimulus, which starts off with our P wave. Our P wave goes off at the sinoatrial node, the atria contracts, and finally we end as the atria contracts, and then we get the mitral valve closure. We get the mitral valve closure because now the pressure in the ventricle is going to start to exceed the pressure in the atria, and that happens as that electrical stimulus from the sinoatrial node travels down through the AV system and into our His Purkinje system. And that pressure, those cardiomyocytes in the ventricle will begin contracting, and again the cycle goes on and on and on. That basically has pretty much summed up most of our cardiac cycle. Now I'm just going to tie some things together, and like I said, I was going to talk about those jugular venous pulses, the JVPs, which are indicated by the A, C, and V, and what's not labeled on this diagram are our X descent and our Y descent, and I'll kind of just briefly talk about that as well, okay? And then end with our phonocardiogram as well. Okay, so our P wave, we said our P wave talks about our atrial contraction, leads to the atrial systole. What we haven't mentioned right now is our QRS complex. Now our QRS complex coincides with our ventricular contraction. So we see a pattern here is that the electrical impulse is followed by the actual contraction or relaxation of what happens at the muscle. And this is also a very fundamental physiologic concept that we repeatedly see in multiple systems, namely the skeletal, now the cardiovascular, and other systems as well. So we have this electrical stimulus, that's the QRS complex, and that QRS complex is then going to set off the ventricular contraction, followed by we have this rapid ejection that we talked about that coincides with our ST segment. Now, when you have a myocardial infarct, whether it's a STEMI or non-NSTEMI, that sort of can differ in a ST elevation or depression, and that's something we can talk about in a pathology series. But you can see changes in that electrical impulse on an EKG, on an electrocardiogram, based on ST elevations and depression. So anyway, that ST segment here coincides with our rapid ejection. And then, like we said, as that relaxation, as we see the drop in pressure, that's coinciding with the T wave, which is the repolarization, where our ventricles are starting to relax. So now let's talk a little bit about these A, C, and V. So the A portion, which is our which is the first upstroke that we see in our jugular venous pulse, and we're seeing it right towards the end of diastole within our atrial systole phase. So it only makes sense that we likely, since it's coinciding with the atrial systole, this upstroke in the jugular venous pulse is due to our atrial contraction, correct? So this is due to our atrial contraction. And as that atrial contraction goes away, and then we see this C wave. Now the C wave, so we can see the C wave kind of reaches its peak right at the end of the isovolumetric contraction phase. Reaches its peak right at the end of the isovolumetric contraction phase. So what's going on there? So what that indicates is basically that C wave that shows up in our jugular venous pulse tracing when the ventricle is contracting, and it's contracting at against a closed tricuspid valve, and it's closing against a closed tricuspid valve, which then bulges. Now it doesn't flip open, right? Because that would indicate a regurgitative state where blood is starting to regurgitate back into the atria, which is a pathological condition. This is not a regurgitation, but there is that pressure which causes a transient bulging of that tricuspid valve into the right atrium. And as that happens, you see this upstroke, which indicates your C wave. Then we get this X descent, which is the downward displacement of that closed tricuspid valve. Now we see that descent comes in right after we see our aortic or pulmonic valve open up. As that opens up, we start to see the descent, because now that pressure is sort of relieved away from that tricuspid valve and headed toward our pulmonic system. And so we start to see that descent in our jugular venous pulse. There are certain state in which this X descent would be absent, and that would be something like a tricuspid regurgitation, right? Because you won't see this descent. This descent would disappear because there's going to be a constant pulse that's felt because of the regurgitation that's occurring. So we wouldn't necessarily see this descent, and that's why these things are really important. And I said this last time as well, that being able to understand this is essential in being able to understand pathology and how things can go wrong. Because if you understand that this descent is happening because of that displacement of the valves, you'll understand that as that contraction, as that valve, the pulmonic aortic valve opens, you should see this X descent. And if that's not there, something is wrong. Anyway, so moving on, then we see this V. Then we see the V wave. And this right here is because you can see it coincides, the peak of that wave is coinciding with our isovolumetric relaxation now. So at this isovolumetric relaxation, our mitral valve is closed, our tricuspid valve is closed, and our pulmonic and aortic valves have also closed. So what happens here is that you see this V wave, and the reason you see that is because there's a filling, a rapid filling of the atria against a closed mitral valve. And because there's no valve leading into the right atrium, or the left atrium for that matter, because there's no valve leading into it, you see a little bit of that peak in the jugular venous pulse, and that's indicated by the V wave. And then followed by that, at the end of it, that tapering that you see is the Y descent, and that's typically seen with the right atrium emptying. Right after that isovolumetric relaxation, as that ventricular pressure drops below the atrial, we start to see the Y descent, and that's due to the emptying. Now, in cases when that becomes a little bit more prominent, can be something like a pericarditis state, or where you might not see it would be a cardiac tamponade. Again, these situations we can talk about later, what exactly is going on pathologically, but those are cases where you might not see it, and it's really important to understand why you're not seeing it. Lastly, let's conclude with our phonocardiogram, which is our heart sounds. So we've got the first heart sound, we've got a second heart sound. These two are the most commonly seen. A third and a fourth heart sound can sometimes be present, but not always. And a third heart sound can be indicative of a normal state or a pathologic state, but a fourth heart sound is generally indicative that something is abnormal with the patient. So anyways, the first heart sound coincides with our mitral and tricuspid valve closure. Okay, so this right here, we can see our mitral and tricuspid valve, as they close, they cause this first heart sound to appear right as our systole starts to take effect. The second heart sound, on the other hand, is due to the aortic and pulmonic valve closure. So you can see that coincides with this aortic valve closure step right here, and that is our second heart sound. Now, in early diastole, in the early diastolic phase, when I talked about this passive and active filling, you can sometimes see this in this rapid ventricular filling phase. You can sometimes hear that third heart sound. Like I said, it can be an abnormal state, or it can be a normal state. And sometimes in pregnant women, this can be a very normal third heart sound that you can often hear, but it can also indicate an abnormal state, such as a regurgitation or in a state of heart failure. And the fourth heart sound, which typically would occur late in diastole, it would be heard late in diastole, and this indicates a ventricular non-compliant state that's usually associated with hypertrophy. So this is when the left atrium has to really push hard against that left ventricular wall, and that is when you'll hear that S4 heart sound, and that is always indicative of a pathologic state. So that would be the fourth heart sound that would occur late in diastole, the third heart sound early in diastole. Okay, everyone, thanks so much for listening. I'm sorry if it got a little bit long-winded, but I just wanted to go through and sort of tie everything together in the cardiac cycle and all these things that you would often see in a textbook or a lecture, kind of tied together. If you have any questions, feel free to let me know. Well, I just want to take this time to thank you guys for listening to the video, and to all those who subscribed already and watched the video that I made first on the pressure volume loops, thank you so much. If you'd like to go ahead and watch that video again, or for the first time, go ahead and click on the right side of the screen, and if you'd like to subscribe, click on the left. Thanks so much.